Erin will present early morning on the date of her surgery, and then she will go to the preoperative area where they will start an IV, start running some IV fluids. She'll speak to the anesthesiologist, she'll speak to the nurse in the room, and she'll also speak to me, and I will just make sure she doesn't have any additional questions. I review the consent form one last time, and then we go back together to the operating room. The first 30 minutes when we're in the operating room, we're actually setting things up. Erin's going to sleep, she doesn't remember it, she doesn't feel it, and we give her pain control as well. That's the job of the anesthesiologist. Once she's completely ready, we prep her, we put a solution on that kills all the bacteria that could be on her skin. She then receives a preoperative antibiotic, and then we begin the operation. I make an incision at her belly button. I try to keep this as cosmetic as possible. So all the incisions are about the tip of the pinky size. So they're about 5 millimeters, the biggest one being just about 1 centimeter in width. And then I begin the operation by putting in trocars, which are instruments that go inside the body, which allow me to stand upright and watch her operation on high definition screens that are magnified. So for me, it's actually easier to be able to do this laparoscopic or minimally invasively because I can get into areas such as underneath her ribs or her chest bone to get access to where her esophagus comes into the abdomen and joins up with the stomach. I start by making a connection between the small intestine and the small intestine, which is the part where the digestive juices will mix up with the food. I then make the connection between the smallest tiny stomach pouch that I make, and I use a stapling device. So I put a sizing tube in, and then I staple alongside it. It's like cutting out a pattern so that the new stomach goes again to about the size of a thumb. I'm not removing anything. I'm bypassing about 95% of her stomach. So 95% of her stomach will remain in the abdomen and it's not removed. It's simply bypassed. That stomach still has an important job to secrete stomach juices. The liver still secretes bile. The pancreas still secretes its enzymes. All those digestive juices still go, but they don't meet up with the food until farther downstream. So the gastric bypass is both a restrictive operation and a slightly malabsorptive operation because of these two, because of the bypass mechanism. When I'm making the connection between the stomach pouch and the small intestine, I staple the back side of it and then I hand sew the front side of it because I feel that this minimizes the risk of it becoming narrowed or stenotic or strictured down, meaning I don't want it to be too tight afterwards. I want her to be able to eat and drink, but just feel full with smaller portions. I don't want her to have a problem with swallowing or vomiting or feeling that foods are getting stuck. So that's why I do the technique that I do. After I make the connection between the stomach pouch and the small intestine, I do a leak test in the operating room. That is where I clamp the small intestine, I submerge the entire connection between the stomach pouch and the small intestine underwater, and then I actually scrub out of the case and go back in and put an endoscope or a camera into her mouth while she's still asleep in the operating room. I blow that connection up as hard as I can, and what I'm trying to do is see if I can force out any bubbles into the fluid. So if I see a in the fluid, I know that there's a hole somewhere and it's not an airtight seal under pressure. So I repair that hole, repeat the study, and I won't leave the operating room until I feel very confident that is a 360-degree airtight connection under maximal pressure. Typically, our patients are in recovery for about 2 hours. After that, they always get their own private room on Unit 48. And once she gets there, she knows she has a very big responsibility to get up and start walking. Walking helps with the gas pains that I put in to do the leak test and also from blowing up her abdomen to do it laparoscopically. And once she starts walking, it helps to relieve the gas to help it move downstream in her GI tract, and she eventually will pass that gas out. So the majority of my patients go home the day after surgery. She's walking the day of surgery, she's sipping liquids the day after surgery. I don't use a Foley catheter the majority of the time, so she's actually urinating in the bathroom right after surgery, not in a bag.